Good afternoon, everyone, and welcome to this early detection and molecular monitoring of breast cancer panel discussion. We're really excited to be here with you today and to share some of the exciting advances that are going on in our ability to monitor breast cancer, understand potential risk of recurrence of breast cancer, and to guide in a much more precise way our treatment of breast cancer based on new and innovative technologies related to molecular monitoring and molecular diagnostics. Today, we have 4 really exceptional faculty members from the Mass General Cancer Center Breast Program. These are really the rising stars of our program who are each leading innovative areas of research that promise to ultimately really transform how we monitor and treat breast cancer. A few housekeeping issues to begin with. I'll be introducing each speaker one by one. We'll be taking all questions at the end of the presentation, and we'll be sure to try to leave enough time for your questions. When you're submitting questions, please submit them into the chat function. You can submit your questions into the chat at any time during the presentation, and we hope to be able to get to as many as possible at the end and have interaction and discussion of questions that arise during the course of the presentation. So up first, it's really my pleasure to introduce Dr. Doug Michelizzi. Dr. Michelizzi is the clinical director of the Early Detection Clinic at the Mass General Cancer Center, where he and his colleagues are trying to leverage very exciting new technologies for the early detection and interception of cancer. So, Dr. Michelizzi, the floor is yours.
Great. Thank you so much, Dr. Ellison. It is an absolute pleasure to be here this afternoon to talk with you about a subject that is near and dear to my heart, and that is the early detection of breast cancer. And I'm just going to share my slides here. Okay. And so what I want to do is tell you a little bit about early detection and what we're doing here at MGH with a new clinic that is now operational in MGH Waltham. But before I get to that, I want to go over a little bit about the rationale for what is early detection of breast cancer and why it is so important. I also want to go over the current status of early detection and what we're doing now for breast cancer screening and early detection, and then really get into some of the very innovative and I think emerging technologies in the early detection space to give you a little bit of a flavor what we're working on and what we look forward to in the future. So first, to start off with the rationale for the early detection of cancer. And I don't think I have to tell everyone too much about this, but the breast cancer comes in a lot of different types. And one of the real key features of a breast cancer diagnosis is what stage it is diagnosed at. And I've shown this here in this diagram as an idea of moving from earlier stages, stage 0 or stage 1, to later stages. And this depends on a lot of different factors, including the size of the tumor, the extent to which it has spread. And so the real key rationale for early detection is by detecting breast cancer and other cancers too at an earlier stage, we are catching it at a time when it's more treatable and more curable. And you'll hear a lot today also about the real excitement in some of the later stages treatments from other panelists today. And so we're also very excited about those treatments. But for my part of this talk, we'll really focus on how we can think about shifting our diagnoses to an early stage. And as I mentioned, this is really key for determining then overall prognosis for breast cancer. And this diagram depicts that. So if breast cancer is diagnosed at the earliest stage, the 5-year survival, the number of women or men who are alive after 5 years is exceedingly high. I mean, you can see here greater than 95%. However, if a individual is diagnosed at the latest stage, you can see that the overall survival is much less. And so by being able to pick up breast cancer earlier, we can then have more treatable and more curable disease. And so how have we done this? Breast cancer has actually been a leader in this area for a long time. I mean, mammograms have been around for a long time, and this has been one of the key areas of developing technologies that detect breast cancer early. And so as I think most everyone is aware, the current recommendations really recommend if you are at average risk of breast cancer to have annual mammograms, generally starting around the age 40s. And so this is the current standard for average risk folks to have breast cancer screening for exactly the rationale I described here, which is to try and pick up breast cancer at an earlier stage. We are also in breast cancer, in the field of breast cancer screening, advanced in the sense that we're also tailoring our screening to an individual's risk. And so, how do we do that? That is currently with the addition of breast MRI screening to those annual mammograms in individuals who may be at increased risk of cancer. And this could be for a variety of different reasons, including a family history of breast cancer, certain exposures, or maybe a germline mutation that they carry. And so in these situations, we intensify or enhance the screening by adding a breast MRI. And so this is really one of the key parts then of thinking about screening, is thinking about how to do a accurate and reliable cancer risk assessment that then moves us to thinking about how to tailor that cancer screening with then effective early detection methods. And so that's really depicted here as we move into, okay, where can we improve? Where do we see the research moving in the future? And so this diagram is meant to sort of illustrate then the idea of taking, a general group of folks, the general population, then being able to do an effective risk assessment where we start to identify individuals who may be at higher risk or may be at lower risk. Once we can do that, then we start putting them into groups based on that risk, and then tailoring our cancer screening in order to match that risk. And so that's where we can potentially de-escalate or de-intensify screening or intensify screening based on this risk. And I think that's an area that is really expanding and where we hope to go in the future. And so how are we thinking about doing this? So right now, again, breast cancer has been a leader in developing some of the important algorithms that can determine and estimate cancer risk. But I think there's room for improvements here. So I think with better algorithms, identifying potentially new or novel risk factors, and then using some of these new and emerging tools of artificial intelligence to really combine all this information into a then a calculation of a risk score. And so this is an area that I think is going to continue to expand, and really we're hoping to be at the forefront of this. The other way that I think is important is thinking about novel ways to assess risk. So we know about some of the more traditional risk factors, but what about taking a mammogram and instead of using it just for the detection of cancer, to actually use the mammogram to predict future risk? And you may not have thought that that would be possible, but actually some of the researchers and providers here at MGH in our radiology department and in collaboration with MIT have been working on exactly this, both in mammograms and in breast screening and in lung cancer screening with low-dose CTs. And I think this has the potential to really redefine how we do cancer risk assessments. And so this imaging and this analysis of the imaging using these novel algorithms, I think, is really going to move the field forward. But in addition to these imaging findings, thinking about ways that genetics or other blood-based markers may be able to also assess risk and move that area forward. On the other side of this, thinking about more effective early detection technologies. So, we know about the mammograms. Those have been effective and around for a long time. We've had improvements of those with the addition of digital mammography and with tomosynthesis, which are some ways to improve mammography. But are there other novel imaging modalities that we could use? If it's MRI technology, we have folks in our Martino Center working on this. We also are thinking about new tracers. Are there things that we could administer that really light up the breast cancer for a particular image and really identify, hopefully, as early as possible? And then one area that we're very excited about is blood-based screening. So this is, instead of looking at an image, actually taking a blood sample and using this as a way to detect breast cancer or other cancers. And these tests are now, becoming commercially available, and I think we need to learn a lot more about them, but we're really at the forefront of this in our early detection center. And so, as we look forward here, we're really excited to have our early detection center in Waltham, where we can focus both on, the clinical care of patients and hopefully identifying individuals who may be at increased risk and helping them understand their risk, and then matching that to the appropriate screening. But at the same time, then incorporating really these novel research questions that we need to answer in order to move this field forward. And so with that, I'll stop sharing here, and hopefully that gave you just a little bit of a flavor of what's going on in the early detection field that we're so excited about.
Thank you very much, Dr. Michelizzi. That was very interesting. And I would say that there is a complex landscape of early detection and early interception. And I think the concept of the Mass General Early Detection Clinic is to help folks who are interested in this, may have key risk factors that would warrant early detection, to help them navigate this complex landscape that's emerging about how we might optimize early detection. So I think it's a really exciting field that is soon going to be part of clinical practice. Our next speaker is Dr. Ariel Medford. Dr. Medford has a really stellar Mass General pedigree, having trained at Mass General as a medicine resident, a chief resident in internal medicine, followed by oncology fellowship within our Mass General and Harvard Cancer Center program. And she has, during that training time, established herself not only as a very gifted oncologist in practice, but also someone who has received extensive training in molecular and computational analysis, which is the new and emerging field in medicine by which one can make sense of the complex data sets that emerge from these exciting new technologies. And Dr. Medford in particular is focusing on how we can use the technologies to more accurately and precisely monitor the status of disease when we don't have evidence by X-rays, scans, or even tumor markers, traditional tumor markers, of the status of the tumor. And so with that, I'd like to turn over the floor to Dr. Medford.
Thank you so much, Dr. Ellison. And I believe Belle will be sharing screen as we click through. Thank you so much. Wonderful. And then we can go into presentation mode. Beautiful. So as Dr. Ellison mentioned, yeah, and let's actually pause before expanding, or we'll just keep going with the slide. So I'll call your attention. So we'll be talking about a concept that I've been very interested in for the past many years, originally in the laboratory, then taking it to the clinic. And then, as Dr. Ellison mentioned, now this relationship between the clinic and then computational genomics work, and looking at what we can learn about how DNA is shed into the bloodstream by tumors. And so if we look at the top right of the screen, you can see, a very simple depiction of a tumor cell. And so if we think of that as a cell, in that center dark blue piece, that's DNA. All cells have DNA. All cancer cells would have DNA, and then that red tube is a simple depiction of blood. And so to some degree, all cells throughout the body shed DNA into the blood. And when that DNA is contributed by the tumor, we call that circulating tumor DNA or ctDNA. And when we look down at the graph below, we can think about what we generally understand about the kinetics of ctDNA to be in patients who experience breast cancer. So ostensibly, in the beginning, when a patient is diagnosed with an early breast cancer, they have some level of detectable ctDNA in many cases. And then after, if we click once more, after we go through surgery, so a definitive curative intent treatment, ctDNA does not have a long life within the blood cells. It typically is cleared on the order of hours. And so it really should drop to 0 if there's no active tumor shedding DNA. And then if we click again, in most breast cancer cases, or in many breast cancer cases, we typically give what we call adjuvant therapy, so therapy after surgery to help after the surgery clear any sort of microscopic disease. And again, if this is effective, we should not see DNA contributed by the tumor. But if we click again, unfortunately, there are patients who experience recurrences. And our understanding in general is that at the time of a cancer setting up, reestablishing itself within the body, it again starts shedding DNA. And so we typically then detect a clinical recurrence when there is detectable DNA. When we click again, we then start treating. Ostensibly, the DNA levels should drop quite quickly if the therapy is effective. But unfortunately, if we click once more, unfortunately, cancers do typically ultimately acquire the ability to grow despite therapy, and at which case we often see the ctDNA levels grow again. And then if we click once more, clinical progression, when we say clinical progression, we mean disease we can see. So tumors on imaging, on clinical exam, but not specifically the blood when we're talking about a clinical progression. And then if we click once more, this is when we would then change therapy if we see evidence of the disease growing. So if we click again, let's kind of rethink this image now, because it used to be that you needed a pretty high level of ctDNA to be able to detect it in the blood. But new, novel, innovative, and exciting technologies that we're really leveraging at the MGH to really provide a future of improved breast cancer care for patients is this idea of detecting ctDNA before it's become metastatic and where cure is no longer on the likely horizon. So if we click once more, the first concept would be, well, what if the ctDNA doesn't clear? I said that it ends up, surviving, or sorry, I should say circulating in the blood for only a matter of hours. And so after cure, it really should disappear. But if we click once more, if it doesn't, we think of that as residual molecular disease. So the DNA is not cleared, and that's concerning that there is some sort of continuing existence of cancer cell shedding DNA. And if we click once more, another concept would be, well, what if it clears, but then ultimately we start detecting DNA again before the clinical recurrence, so before we can see it on exam or on X-ray. And clicking once more, this is the encompassing term molecular residual disease. And this is now detectable because we now have very, very sensitive tools for being able to take a tumor, look specifically at all of the mutations that are specific to the tumor, and have a very refined and sensitive test that we can assess for in blood samples. And so it's important here to understand that patients typically do not undergo do not undergo regular systemic imaging, because we know that in the setting of breast cancer, that's often not going to change patient outcomes. And so we're really talking about a tool that would really overhaul the way that we think about assessing for any sort of residual cancer. And so we're doing a lot of things in that space now. Actually, we'll go back. Thank you. So within that space, what can we learn? So first, a lot of the research we're doing is looking at which patients are likely to experience residual molecular disease. I mentioned we do a lot of profiling of the DNA itself to understand where this is coming from. We're doing a lot of research onto what that DNA can tell us about patients' recurrence risks, which patients are most likely to develop it, and what we know about the dynamics of it, if it drops very, very low, or if it drops low and then starts increasing higher, and how that changes the patient outcome and patient experience. And then if we click again, I think the most important question is, well, can we change experiences for patients? Can we improve outcomes? And really the ultimate hope would be in the adjuvant space, so the space before a patient has experienced recurrence after surgery. Can we actually increase the number of patients that are cured of cancer by using this as a metric for which patients need more escalated therapy? So if we click again, what we're assessing is, we have, in the setting of a patient with residual disease, what if we add additional therapy? There's data right now that tells us that if patients have residual disease, unfortunately, the chance of the cancer coming back is exceptionally high. But if we click once more, our hypothesis, the question we have, and we click once more, is what if we change this natural trajectory? Can we either cure cancer, which is obviously our ultimate goal, or by escalating therapy, can we effectively turn this into a chronic condition where we give therapy, but the disease itself doesn't actually come back? So turning cancer more into a chronic condition. And this is something that's been achieved in our liquid tumors, more like some of the chronic leukemias. And that's one of the hypotheses we're testing as well. And so we're looking at the level of ctDNA after we do these escalated therapies. And if we click again, and thinking of a similar situation, so if patients have undetectable DNA, but if we're monitoring for it, and then we click again, what if we start seeing that rise? As you saw in the earlier slide, that typically would end up with a patient ultimately experience a metastatic progression where cure is no longer achievable. But if we click again and click once more, all right, so what if we then escalate therapy at this time point, so long after the surgery, but at the time that we have a molecular evidence of disease, then click once more. Again, our question is, can we change outcomes? Ideally achieving cure, and even if cure is not achieved, can we change outcomes? And so, and prolong time to recurrence or prevent recurrence, even if the circulating tumor cells are more in kind of a dormant state. And so the ultimate goal is to cure more cancer. And the last piece there is, for patients who don't experience molecular recurrence, I think a long-term goal would also be, are there patients who don't need all of that adjuvant therapy? Are there patients we'll ultimately be able to identify who need less therapy? And I think we're a little bit further away from that, but we're actively doing research to lay the groundwork for that as well. And so, the MGH right now, we're running one of the leading clinical trials in this space, looking at escalated therapy for patients with molecular residual disease in estrogen receptor positive HER2 negative breast cancer, the most common type of breast cancer. Looking forward to presenting that data when it's complete, so that we can see how we are able to impact patients at that level, with a lot of translational work. So a lot of work we're doing in the lab to understand where this DNA is coming from and how we can further impact patient lives using it as our informative approach. So thank you so much. And please put any future questions in the chat so we can discuss at the end of the session.
Thank you very much, Dr. Medford. As I reflect on this field, I think that it's so relevant in particular to breast cancer, because I really believe that this kind of innovative molecular monitoring is going to allow us to know, as you described, which patients might have molecular residual disease who need further therapy in order to ensure cures, but also to help inform which patients may have received enough therapy and maybe allow us to more precisely de-escalate therapy. In other words, to tailor how much therapy is needed for cure, no more and no less for each patient. So really very exciting. Our next speaker is Dr. Seth Wander. And Dr. Wander, is, really what we call the triple threat in terms of physician scientist. He has an MD degree, a PhD degree. He's had full clinical training, basic science training, and translational science training that he's applying to a really exciting research program. Dr. Wander is emerging as a national leader in the area of understanding drug resistance, particularly in the setting of a patient who receives a typically effective drug, but then unfortunately suffers disease progression, and trying to understand how at the level of individual patients that progression occurs, why it occurred, and how understanding it may allow us to know what would be the next best therapy for that patient and how to give better therapies in general going forward is really what Dr. Wander has focused his mission on so far to great success. And so, Dr. Wander, I'll leave it to you. Thank you.
Thank you, Dr. Ellison. It's a great pleasure to be with everybody today and hearing about all these really, really exciting ongoing research topics. We're going to switch gears slightly. We've heard over the last few minutes about some topics of interest in the setting of early stage disease in terms of early detection and circulating tumor DNA monitoring. I'd like to spend a couple of minutes today describing some really exciting, evolving treatment paradigms in the field of metastatic breast cancer. And we'll focus mostly on hormone receptor positive metastatic breast cancer, or estrogen sensitive metastatic breast cancer, which is the estrogen sensitive breast cancer being by far the most common. So in this situation, we'll talk a little bit about some of the newer therapies that have just recently entered clinical practice, and I'll describe some of the efforts that we are pursuing both in the clinic and in the laboratory to help deliver upon the promise that Dr. Ellison was just alluding to, the concept of precision oncology and personalized medicine. So let me share my screen. Okay. So this is a roadmap summarizing about 50 years of progress for metastatic hormone receptor positive breast cancer. And I often will, say to some of the patients that I'm meeting with in clinic that breast cancer, we really were the tip of the spear in terms of delivering upon personalized medicine with really the first targeted therapy of any sort in oncology back in the late 1970s with tamoxifen. So during the 1970s and then subsequently in the 1990s, we saw the development of the first and second generation oral anti-estrogen therapies, tamoxifen and then the aromatase inhibitors. And these drugs really revolutionized the way we treat breast cancer, of course, because they are oral, they're generally very well tolerated, and they're very effective at both preventing disease recurrence in early stage disease and also controlling disease growth in more advanced stage 4 or metastatic disease. In the early 2000s, we saw the first selective estrogen receptor degrader, fulvestrant, which in its earliest form, and that we've used over the last couple of decades, is an injectable medication. And then after 2010, we began to see the development of new, what I would call targeted therapies. So first we saw everolimus, which is an mTOR inhibitor targeting a critical piece of the machinery that allows cells to grow and divide. And in 2015, the field of metastatic breast cancer was revolutionized again with the development of cyclin-dependent kinase inhibitors, palbociclib, ribociclib, and abemaciclib. These drugs over the last 5 or 6 years have now become the standard of care, typically in the first line setting for stage 4 breast cancer, and have really conveyed impressive benefits in terms of both controlling the growth of the cancer and in some cases also able to prolong patient survival over a period of years. What's been even more exciting, just in the last couple of years, we've seen 3 new drug approvals in this group in metastatic ER-positive breast cancer. We saw the first PI3 kinase inhibitor, alpelisib, in 2019. And this year, we had 2 really exciting approvals. the first oral selective estrogen receptor degrader, elacestrant, and the first AKT inhibitor, capivasertib. So both alpelisib and capivasertib, like everolimus, are drugs that are oral. They're generally well tolerated. They are not chemotherapy, and they are specifically designed to target components of the cell machinery that allow the cancer cells to grow, survive, and spread to other parts of the body. Elacestrant is a descendant of fulvestrant and is actually the first of a new generation of oral anti-estrogen therapies. Again, highly well tolerated and very active, even in the setting of resistance to the original anti-estrogen therapies that were developed in the 1990s. All of this demonstrates our commitment to trying to reduce the burden of toxicity, limit the use of more toxic, non-specific conventional chemotherapy, and focus on the development of newer, generally oral, very well-tolerated drugs. I put little stars on these last three because they represent a really important paradigm shift in breast cancer. These three drugs were all recently approved based on the presence of specific genetic mutations that are required in the tumor. We just heard from Dr. Michelizzi and Dr. Medford about this really exciting new technology that allows us to take blood samples from patients, separate tumor DNA in the blood from normal DNA, and then actually sequence the genes that are normal or abnormal in the tumor. And each of these three new drugs that have just entered clinical practice require the presence of specific mutations in the tumor that make that tumor particularly vulnerable to these drugs. And I think this is the first in a wave of new opportunities that we and others are working on to develop highly personalized, effective, and minimally toxic therapies to improve control for metastatic ER-positive breast cancer. And I want to spend the last couple of minutes talking about that in more detail. So what you see on the top is an example of this technology that Dr. Medford was just teaching us about. This is a circulating tumor DNA profile. And what we're seeing here are two different time points, one obtained at diagnosis and the second blood sample from the same patient obtained after the tumor started to grow and develop resistance to standard anti-estrogen therapy. The total width of this picture here demonstrates how much tumor DNA is in the blood. So you can see when it becomes resistant to the anti-estrogen, there's more tumor DNA in the blood. And each of the different color bars within this picture represents a different gene. So you get a lot of information here about which genetic changes were present at the beginning, and then which new genetic changes arose after the tumor became resistant to a specific drug. And in this particular example, we see two alterations, one in a gene called PTEN and one in that gene called ESR1, that allow us to reach into our pocket and use two of the newer drugs that we were just talking about on the prior slide. So in a very personalized way, we're able to take this information, talk with the patient, look at our toolbox of currently available drugs, and in an instant like this, actually reach for a personalized drug that's specifically targeted to the genetic change in the tumor. So based on work from our group and others, we've created a kind of thought paradigm that you see on the bottom of the slide here. If you think about patients who have metastatic hormone receptor positive breast cancer and then become resistant to those standard hormonal therapies and CDK inhibitors, it's very unlikely that a one-size-fits-all approach will be beneficial because each individual patient can develop resistance to these drugs through a variety of different genetic mechanisms. And so we've proposed a model where you can take a blood sample from the patient at the time of progression, identify the specific genetic alterations, which we're labeling here. Each of these boxes is a different gene that we've proven in the lab and in clinical samples provokes resistance to these drugs. And then below here, you can see we can reach into our toolbox and pick a specific targeted drug that would be best suited for that patient. So we have a number of different projects going on right now at MGH where we're trying to use this very personalized information to develop next generation clinical trial opportunities where patients can reach for these individual drugs based upon the changes in their tumor. And it is my opinion, and I think the opinion of many others who are doing this kind of work around the country and around the world, that the future of oncology care looks a lot like this, where we're taking serial blood samples, we're monitoring the change in the overall tumor burden, we're looking at the rise and fall of specific mutations, and we're modifying treatment plans for patients in real time based upon these changes. Much similar, much in the same way that Dr. Medford was just describing for monitoring in the early stage setting. But here we have actually known tumor that we're following, and we're dynamically changing drugs now in the setting of clinical trials, but we hope with additional progress in the future that this will become the standard of care and the treatment approach that can be utilized, anywhere around the country and eventually around the world. So with that, I will pause. These are very exciting times. We have lots and lots of new ongoing translational research projects and new drugs coming online at a rate that we haven't seen in metastatic breast cancer really at any time in history previously. And so we're really looking forward to pushing this work forward and happy to take any questions at the end. So I will turn it back over to Dr. Ellison.
Thanks very much, Dr. Wander. Whenever I hear you speak, I'm truly excited by the promise of this rational and very patient-focused way to understand treatment resistance and guide therapy. But I also have to say that I'm humbled by the complexity of what you described. And clearly, the answer to that sort of paradox is that it's the research that's really going to allow us to, understand, cope with, and really utilize that complexity to improve therapy for all of our patients. So, and I think there's no one better to be leading these kind of efforts than you. So thank you very much.
Thank you.
Now, our final speaker of the afternoon, Dr. Nilima Vedula. It's really my pleasure to introduce Dr. Vedula, who is really emerging as the leader in the area of unmet needs in precision oncology and breast cancer therapy. And Dr. Vedula has shown a remarkable capacity to lead a diverse variety of programs that really have an extraordinary impact on patient populations who typically aren't served by the standard one-size-fits-all sort of therapy approaches. So I'm very excited to hear an update on Dr. Vedula's research program. So Dr. Vedula, I'll turn the floor over to you and you can share your slides.
Thank you so much, Dr. Ellison. Thank you so much to the development team for having us today. And thank you also for everyone who's participating in this wonderful webinar. I think that empowering ourselves by understanding advances in the field is certainly beneficial for everyone, both patients and physicians. So I'm going to go ahead and share my screen here. Hopefully you can all see that. And are you able to see my screen?
Good.
Good. Okay, great. Wonderful. So today I wanted to talk a little bit about tumor evolution and how that can factor into therapeutic opportunities. So we know that unfortunately patients who have advanced breast cancer or metastatic or stage 4 breast cancer, that's unfortunately a disease that is a chronic disease. It's manageable, but with time it will stop responding to our standard therapies. And one of the ways that we have actually been able to further understand these types of changes in the way the cancer is behaving and potential other treatments is by using what we call tumor tissue or plasma-based genotyping. So with time, tumors can acquire certain types of mutations. Those are changes in the tumor's biology that might make them more or less likely to respond to a given treatment. And using some of these genotyping assays can help us to identify those within the tumor. So in terms of tumor tissue genotyping, that's taking a sample of a tumor tissue. For example, if a patient has had a biopsy of a site of liver metastasis metastasis or a bone metastasis or some other site, and looking at it and looking for certain types of mutations that are enriched within the tumor to see if they may be contributing to resistance to other treatments, or whether they might also be opportunities to target those mutations with the treatment. And a similar approach is used with plasma-based genotyping, which is a blood test. I think some of you may be familiar with the testing platform called the Guardant 360 platform, which we're often using a lot at Mass General. And so this is essentially a type of testing where a patient undergoes a blood test, and the blood test is actually detecting bits of DNA that are shed by the tumor into the blood. And once again, this can be used to identify mutations from the tumor that are actionable potentially and found in the blood. So this approach nowadays is something that is being used more commonly, and especially at our center at MGH, we've really been at the forefront of evaluating how we can use these different types of tissue-based and plasma-based platforms to help identify mutations that are shed by the cancer or within the cancer for potential intervention. So I wanted to, show one of the studies that we actually conducted a few years back that was a proof of concept, where we actually looked at our database and repertoire of patients with advanced breast cancer who were treated at Mass General. We had more than 300 patients, and some of these patients had undergone this tissue-based genotyping testing. Those were 118 patients, and 252 patients had undergone blood-based testing. And when we did that type of analysis, we were looking to see how many of these patients had a mutation that you could potentially do something about, an actionable mutation that you might be able to consider a treatment for. And in this study, we actually found that of the patients included in the study, almost 80% of them had some kind of mutation that you could find in the blood using a plasma-based assay. That's the cfDNA assay indicated in this pie chart. And in terms of the tissue-based genotyping, about 50% of patients who were tested had some type of a mutation. And I think that this work really shows that there is a potential to identify mutations that are within the tumor or shed by the tumor that we could potentially do something about. And so these types of assays are really important for the care of patients with advanced breast cancer. And indeed, in a certain kind of breast cancer, hormone receptor positive, HER2 negative disease, this is actually considered as a standard of care because there are certain actionable mutations, such as a PIK3CA mutation, that you can give a targeted therapy for. We then went on to analyze, based on the presence of having a mutation by one of these assays, either within the tumor or shed by the tumor, how many patients were actually able to ultimately get a matched targeted therapy, meaning a therapy that was geared towards the type of mutation that was present. And we found that of the patients who had a cell-free DNA mutation in the blood, 34% of them were ultimately able to get matched to a therapy, and about 11% of patients who had a tissue genotyping assay mutation could get a matched therapy. So this was actually a relatively high rate of receiving matched therapies, and it speaks to how this approach may potentially help us to find ways to better serve our patients. And then when we looked at the impact on survival, even though this was a retrospective analysis, meaning an analysis done on patients already treated, not patients enrolled in a new trial, we did find that there was a potential survival benefit in patients who got matched therapy, as shown with the red curve here, if they had a mutation, compared to patients who did not get a matched therapy. So this is an area of ongoing research interest in precision oncology, and we're continuing our work in this area. But I also wanted to highlight how these assays can also help us to find new targets for intervention. So a couple of years back, we led a study where we looked specifically at a type of mutation called a BRCA mutation. Now, you may have heard about that mutation in the context of patients who are born with a mutation called a germline BRCA mutation. But it turns out that some tumors, some breast tumors, can also develop these kinds of mutations, and those are mutations known as somatic BRCA mutations. So when we analyzed our patient cohort population at Mass General of patients who had blood-based cell-free DNA testing, we found that a good portion of them, almost 14% of them, had these cell-free DNA BRCA mutations that were somatic. Not all of them are likely to respond to a targeted therapy for BRCA, but some of them might be, and that those are the ones that we've classified as known germline pathogenic using a variety of genetic databases. And then we actually worked with one of the labs at Mass General to develop a culture from a patient who had one of these mutations and demonstrated that having a mutation, a somatic BRCA mutation, might actually report sensitivity to a PARP inhibitor, which is the kind of treatment that is approved in patients who are born with the germline BRCA mutations. So based on this work, we actually developed a clinical trial that I'm leading at multiple sites in the country, and we're enrolling patients at Mass General as well, where patients who have a tumor or a blood-based BRCA somatic mutation are eligible for treatment with this targeted therapy, a PARP inhibitor. So this is really exciting work because a PARP inhibitor is an oral type of therapy, and it affords us the opportunity to enhance the number of patients who might be able to benefit from an oral treatment. So this is some work that we're really excited about. And then just to close here, I also wanted to just talk for one moment about our chest wall disease clinical and research program. So unfortunately, some patients with breast cancer can develop cutaneous metastases on the skin and the chest wall. And this is an area of terrible unmet need. You know, patients who have this disease, unfortunately, this type of disease tends not to respond very well to our best treatments. So we actually have an ongoing clinical trial that is that we're still looking for patients where we're treating patients with immunotherapy and chemotherapy who have this type of disease. But as part of our research program, we're actually collecting biopsies from patients who are, have this type of disease and working with some of the laboratories at Mass General to identify some of these mutations, tumor type of mutations, and also understand the immunologic features of this disease so we can come up with better ideas and better ways to treat this disease in the future. And this is an area of significant interest for me and many of my colleagues. And with that, I would like to thank you for your attention today.
Thank you very much, Dr. Vedula. That was really a beautiful presentation of so much successful work. And I would say in particular, the idea of the study that you did that gives us a window into the fact that if we can match on these molecular profiles of the tumor, we do have an opportunity to improve the patient's outcome. And I think, you know, that's the kind of data that we would really like to get to know how much success and truly patient-focused advances we're having based on all of this innovative work that's being done. So there are some good questions coming through in the chat, which we'll take in one moment, but I just thought I would pause for a second to reflect on, you know, the huge diversity and extent of the work that you've heard about this afternoon. And in the context of thinking about, you know, what are the elements that accelerate this research? What are the elements that make this research possible? What are the elements that are necessary to drive this research as rapidly as possible? And I would say that all of these elements really come together in a place like Mass General. And what I'm thinking about is the extraordinary clinical care in terms of multidisciplinary care, surgery, radiation oncology, medical oncology, to deliver truly the state-of-the-art care from each discipline. And then I'm thinking about how, with that state-of-the-art clinical care, we're also aligned so closely with the brilliant scientists at Mass General and throughout the Harvard and Boston and national and international communities, deeply embedded and working side by side with the scientists to understand the complexities of cancer. And then finally, applying all that knowledge in the broadest scope in a place like Mass General, which is, of course, a general hospital. So we're thinking about the patient's wellness from the point of view of their cancer, but in a way that might also impact, you know, their diabetes, their arthritis, their other conditions that they have. And therefore, I think that in some ways, you know, this is a demonstration of why Mass General is a unique place to make this happen. You know, of course, all this work, particularly work that's on the cutting edge, is not necessarily the work that organizations like National Institutes of Health are always anxious to fund. You know, they tend to be rather conservative, not risk takers, wanting to fund things that are already proven to be effective. So it's really at the cutting edge and things that you've heard about today where philanthropy can make such a difference in driving the research forward. I would say again, right before I take questions, that If any of you would like to hear more about the topics that you've heard about or get involved in any ways in the research program, Belle Camello is our representative from the development office who is on the call and will leave her contact information in the chat. If you are interested, please feel free to reach out with Belle. And I know we are happy to discuss with each of you individually if you're interested in hearing more in detail about the individual research programs. So great questions are coming in, and the audience is really paying attention. So one of the really good questions that came from the audience is, and this will start with Dr. Medford, and the question is molecular residual disease monitoring possible in all types of breast cancer? For example, triple negative or hormone receptor positive, is it possible in all subtypes? And then secondly, what's actually happening currently? How much of this is being done in current clinical practice as a standard, and how much of it is being done in the setting of research protocols currently?
It's such a great question. And so the answer to the first question is yes. So all types of breast cancer can be detected via MRD testing, minimal molecular residual disease testing. And so there have been many largely retrospective studies to date. So studies that are looking back on samples that we have, and now we're working on prospective studies. So collecting data to understand kind of the natural history of these cancer DNA trajectories, but it's been described in all breast cancer types, and there are clinical trials that are being proposed and designed in all clinical scenarios, so triple negative and HER2 positive, as well as estrogen receptor, hormone receptor positive breast cancer. And then in terms of, is this something that has to be enrolled in a study? So as of this past year, not for all patients. So Medicare announced that it was going to reimburse for one type of MRD testing called the Signatera assay for patients with any subtype of breast cancer. So that includes all subtypes, stage 2B or higher. And that actually, I think, really highlights another major clinical need that we're trying to research as quickly as we can. Because what we know about MRD right now is if you detect MRD, unfortunately, patients appear to be on a trajectory of ultimately recurring. It's a very poor prognosis, and our goal is to offer therapies to patients to change that trajectory. However, there's no approved therapy in that setting right now. So we have patients who can have reimbursable commercial testing to identify something that says, yes, there's a high risk that this is going to recur. And yet the only interventions we have right now are largely in clinical trial, which many patients don't have access to. And so it's an area we're trying to research as best as we can, as quickly as we can, so that patients not only can get prognostic information, but actually have an intervention that they can reach for once detected.
Thank you, Dr. Medford. And another very good question is kind of a two-part question. And part one, this is for Dr. Michelizzi. Part one is, which patients at this time would you think are appropriate to consider referral for the early cancer detection clinic? And then the second part is, in general, what guidance would you give to those who have a history of breast cancer in the family who are concerned about their risk?
Yeah, great. Absolutely great questions. So, in terms of our new clinic in Waltham, in the early detection clinic, we're really excited to be able to offer this hopefully very broadly. So we see, patients who may be concerned about their cancer risk because of their family history of cancer, as you mentioned, or because of a mutation that might have been found in their family, or other reasons. Maybe it was some sort of environmental exposure or service in the military, or occupational exposures like being a firefighter, or other things where folks may be at increased risk of cancer. And so we're very happy to see really anyone who's concerned about their risk. And so we have referrals coming in as self-referrals, meaning patients themselves are interested in referral, or from a primary care doctor or other providers across the greater Boston and actually Massachusetts and New England areas who are concerned about their risk. And then the second question, thinking about, someone who's concerned about because of their family history, one of the important things that we're also offering in the clinic is germline genetic testing to individuals, really, quite broadly. Obviously, some of the challenges with that can be just, funding that and making sure that it's not an overwhelming cost. But yeah, I think with the expanding indications for genetic testing, knowledge is power when it comes to this area, and being able to identify gene mutations where, in a family that hasn't had that information can be really powerful in terms of deciding what testing and what screening an individual should be doing.
Thank you, Dr. Michelizzi. Now there's a question that's come in for Dr. Wander. So, Dr. Wander, you described a lot of complexity in terms of the molecular pathways of resistance. So, what do you think is needed in terms of the research in order to accelerate the ability to understand these resistance mechanisms and to apply therapies in a way that are really going to benefit patients in a personalized way? And then the second part of the question is, what are you most optimistic about in terms of this field of resistance matching and personalized therapy?
Yeah, thanks, Dr. Ellison. That's a great question. I think we have a wealth of information, at our fingertips, and we have a lot of different mechanisms to explore that via. So, for example, a lot of the efforts that we've been pursuing over the last few years have been, truly multidisciplinary. And I don't just mean within MGH. I mean across MGH and our collaborators, at other institutions, within industry, et cetera. So, for example, in order to parse what you're describing, and which is a very complex set of patterns related to response and resistance, we've been leveraging multiple sort of data inputs. And as an example, we might use institutional retrospective data. We have research efforts ongoing at MGH where patients can volunteer to participate, provide tissue samples, provide clinical data in a protected health information de-identified way. And we can mine that data to look at different genetic changes as they relate to clinical outcome on specific drugs. We can partner with other institutions who have similar protocols and actually combine that into very large data sets. We can then turn to our collaborators in the real world data space. So, for example, we've talked a little bit about Guardant Health. We've talked about Signatera. There are a number of companies that have databases with, thousands, tens of thousands, hundreds of thousands of samples. And then a third mechanism is we can work in the context of prospective controlled clinical trials, which we do in partnership, again, with industry partners and with other academic institutions. So my philosophy here has been, if you're interested in sort of uncovering or demystifying, right, that network, you look in all of those diverse data sets for the outcome of interest or the gene of interest. And if the signal is present across those varying sources, that's a very strong rationale, right, to go deeper and to move forward, both in the laboratory and in the clinic, validating that genetic point of interest and then trying to develop new therapeutic strategies moving forward. And then the second part of the question, what am I most optimistic about? I think I'm most optimistic that the FDA and our collaborators across the country and across the world share, I think this enthusiasm for the promise of precision oncology. I just showed you the last 3 drugs approved in ER-positive breast cancer, all of which were tied to specific genomic alterations, suggesting that the field is really shifting underneath our feet and moving in the direction of personalized care. I'm optimistic that the new clinical trials that we are designing, opening, and will be reporting out, hopefully within the next couple of years, will continue to build upon that foundation and help us move outside of the research space and actually begin to deploy these therapies as part of standard of care.
I totally agree, Dr. Wander. Thank you. So we're coming down to the last couple of minutes. I'll remind folks, if you're interested, Bill Camello's contact information is in the chat. We'll finish with a question for Dr. Vidula. Dr. Vidula, you've been very successful in creating a multidisciplinary program to address an area of high unmet need, such as chest wall disease. Can you tell us what are the elements that are needed for such a program to be successful?
Yeah, thank you so much for that question. So I think that first of all, in order to have a successful program, you need to have interest, right? So this is an area of high unmet need. And I think many of us who are treating physicians, unfortunately, when we see these patients who have skin and chest wall metastases that are eroding through the skin, but these patients are often, unfortunately, experiencing a lot of pain, often having a lot of wound complications, infections, many different issues. And when we see these patients, we really have our heartfelt, compassion towards them. This is really an area of unmet need, and we really wish we could do more. So when we built this clinical and research program, we actually were able to get a group of individuals who were really interested and passionate about helping these patients. So, I'm the medical oncologist who leads the clinic, but we also have a surgeon, Dr. Verdiel, a radiation oncologist, Dr. Tagian, and a palliative care doctor, Dr. Petrillo, who all contribute and have collaborations with wound care and so forth. We also have collaborators in the laboratory that we worked with to help sustain our research program, because without that collaboration, we're not going to be able to make advances in this disease and to come up with new ideas. And so we have several very interested collaborators who are helping us in the laboratory and helping us identify varying mutations and changes in the immune landscape in biopsies that we collect from the clinical side of things. But the last piece of it that's really critical is also funding. So, we've done everything we possibly can to apply for grants and look for funding to sustain this program, but certainly philanthropic funding and other sources of funding help sustain it, because these types of efforts, they do require money, unfortunately, to understand the biology of the disease, but so oftentimes even a little bit can go a long way. So that's something that certainly we are doing our best to publicize the program. And then the last piece of it, I think, is also outreach. One of the things that we have done to be successful in enrolling to our clinical trial, which is the largest trial that has ever been done in this space for patients who have skin and chest wall metastases, is to put the word out. And we've reached out to, hundreds of physicians across the country, also, made postings on our Twitter site and so forth. But that type of outreach wouldn't also be possible without having patient advocates who are invested in our study and invested in our programs. We actually work with 2 patient advocates who are part of the Dana-Farber Mass General Harvard Cancer Center, and they've not only helped put out the word about our studies, but also helped review our grant applications and helped us to think about things from a patient perspective and how we might get the word out better. So I think it's a multi-pronged approach, but certainly outreach and funding plays a huge role here.
Thank you very much, Dr. Vidula. Well, I'd like to thank everyone on the panel who participated, and in particular, for those of you who were able to attend this discussion. I hope you found it informative. And as I said, we're always happy to follow up. Thanks very much and have a good afternoon.